and uh, we usually treat every patient with some interventions, and we just write the medications or we just prescribe the treatment. But is there any basis for that prescription? How do we do that? So um, this class will be on um, including how we come to a conclusion that okay, this treatment would be needed for the patient, or this is the good treatment for the patient. So we will get an answer for this question. So with this, needless to introduce Sir, because all of you know that he is the chairman of Palim India and director of Trivandrum Institute of
Sunil,
Palliative Sciences.
Sunil, I think we can easily skip the introduction in detail.
Yeah.
Okay, if you don't mind. We
Yeah,
have
yeah.
already
With
done
that,
this.
I am stopping.
Sunil, thank you. Hello, everybody. Sri Priya, one problem with the group is that there are not enough smiles. I was looking around. Parul has been smiling from the beginning, but then everybody is so grim. But thank you very much. Now, Dr. S.A. Raja, except for a very few people like you, practically everybody smiles.
Very good evening, sir. Sorry, sir.
Good evening, good evening. Okay, that's better. We are talking about many grim things. Once in a way, it's good to remember to smile. Thank you. So, Sunil worked in forensic medicine. Oh, maybe long back. How long, Sunil? Maybe 2 years? No.
Yeah, some 19 years back for 2 years.
2 years. Now, that's the one subject where even now medical ethics is taught. As if certainly there is a connection between law and medicine, no doubt about it. So law and ethics, but it's a loose connection. I wish now that AITCOM has come in, attitude, ethics, and communication, even now ethics gets tied to forensic medicine. I wish it would be more closely related to clinical practice in the minds of the students. Maybe it will be. Now, first and foremost, an anticipatory bail. I am totally convinced that there are people in this group who are much more knowledgeable on this subject than I. No, I'm not saying this out of false modesty or anything. I'm not an ethicist. There are people here I know who have studied it much deeper. So please chip in whenever you want to. There we will not bring clarity completely. Not possible. It wouldn't come in as part of the talk, but there is a principle called ethical relativism. Some people call it normative ethics. So normative ethics is professing that what is ethically right depends on what the society thinks right up to a point. That's unfair. Right should be right anytime. But that's the way. Let me tell you an example. Okay, in our country, it is balancing. At a time, at least a couple of people in this group are from close to my generation, and they would know at one point of time it was considered almost unethical not to thrash children. Dr. Biju is smiling, possibly with a cry inside about the number of times he has been thrashed. That was considered the right thing, you see. Okay, people who talk a lot about ethics, medical ethics now, UK. At one time, The proverb was, spare the rod, spoil the child. If you do not use a rod on the child, you are spoiling the child. And today, if you take the rod, you get arrested. And we are at a passing phase. You hear about teachers being penalized for corporal punishment of children. I'm just giving an example for relative, normative ethics. I'll just stick to one word, normative ethics. So things will change. Even now we are at a transitionary phase. And we can feel that actually feel it. We almost touch it in our everyday life, like when we deal with the withdrawal of life support. Yesterday and today, the Supreme Court of India has been hearing a 5-member high power bench has been hearing a review petition by Common Causes. Common Causes, a non-government organization, which moved the Supreme Court many years back and got that verdict of 2018, which said, okay, it's okay to withdraw artificial life support if in the event of futility. But even now, in yesterday's reports about the hearing in Live Law, the online platform, they are asking all the usual questions that you have heard in your extended family. Haven't you heard of Karen Quinlan waking up after so many years? Haven't you heard of somebody unconscious for 21 years and then waking up? Hasn't Stephen Hawking, the Supreme Court judge, brought in Stephen Hawking? How can you say that his life was not futile? The point is missed. So why am I making this long lecture? Just to say that many things in ethics cannot be absolute. With that introduction, shall I share my screen and share with you only some principles of medical ethics. We will not be covering the subject by any means. Sometimes I wonder, what is the point of all our discussions like this in classrooms and in air-conditioned halls at annual conferences? So many of our people are poor. If they were not poor, the treatment over 3 months would have made them poor. And all that we are going to discuss, let us make one vow to ourselves. We will talk remembering this woman. This poor woman lying in their hut, being taken to a hospital, big hospital, every third Thursday or something like that. That's when she has asked to. Will her dignity, I'm not beginning with the usual 4 principles of medical ethics. I'm starting with dignity, not a textbook order. You would know when you look back on your life, some of your worst memories are related to losing your dignity, being ridiculed in public, being accused of something in public that you did not do, being thrashed in school. You are deeply injured, traumatized somewhere in here when you lose your dignity. These poor people from our village, in their life with a lot of suffering, the one thing that they hold dear to their lives is dignity. Most of them live with dignity. And in the hospitals, friends, we have to make sure that we give respect to this person and treat the person with dignity, not offending her dignity as much as possible. We have to show the example. Otherwise, you know what happens in our hospitals. If we are to ensure her dignity or ensure my dignity when my time comes, friends, first, we have to treat her with respect. Something that I have already told many of you. I mean, some of you have gone through this ordeal several times in your life, listening to lectures from me. Raju, this must be the 17th time for you. Jagrati, 19th time. So sorry about that. But this is one point that I'll keep making. Sorry. Every one of you here in this room, in your own rooms, okay, on this screen, is superior to me in some way. I have no doubt about it. And the fact that I know that Sri Priya, when she holds a microphone and anchors any program, does wonders, keeping the audience enthralled. That alone is enough for me to treat Sri Priya with respect. And take the case of this woman. What a difficult life she would have lived as a woman, as a poor woman. Not only poverty, but also gender-based discrimination in our society. And then with an illness like this, which is losing her independence. Are you sure you would have had her courage to go through life with against all that odds? This knowledge that everybody is superior to me in some way allows us to treat people with respect. You and I have no right to be judgmental. People will be judgmental. Somebody who has been a wife beater and an alcoholic, has beaten up his children also, would not be treated with respect in his village. But when he comes to you, even if you know of the kind of life he has had, I hope you will remind yourself that you are the one person who will treat him with respect, knowing that there is something in him, despite all the life that he has had, something in him that must be better than yours. And you, nobody appointed you judge. If anything, I would give extra attention to this man because I want my care to be equitable. Because I know that most of the healthcare system will look down upon him, treat him with disdain. I know that I have a responsibility to give special care to them because nobody else may treat him with care, give him care. He deserves my care even more. It's most important to be non-judgmental. But this is not easy. I can tell you it is not easy. It's not easy for me. When I know so much about a person that's negative, somewhere within me, because I am just a human being, I can feel that anger coming. And I have to try to overcome that and treat the person with a non-judgmental approach. Confidentiality is something that is not at all respected in our society. Medical professionals not excluded, very callous. People's illnesses and personal problems are discussed very callously everywhere. And we will have to remember to not to do that and to show an example to the rest of the world, rest of the medical world. And we will have to remember, as we mentioned in the opening class, that our care shouldn't be too much focused on the disease. Certainly the disease deserves attention, but we should be centering on the person. That means including his suffering. So before going on to the 4 usually mentioned fundamental principles of medical ethics, I wanted to mention dignity and mention these 4 aspects of it. Of course, many things included in this will come, like respecting privacy, not undressing somebody without locking the door, things like that. Before I move on to the usually mentioned 4 fundamental principles of medical ethics. Would somebody like to ask a question or post a comment? Sri, will you monitor the chat box and warn me?
Sure, sir.
So that I can concentrate on my friends and not on the screen. Yes, Dr. Kavin Kumar, prejudice must be avoided. But Kavin, we are human beings. We may tend to be prejudiced. So we have to keep reminding ourselves, hey, stop. You are being prejudiced. Thank you. Or shall I move on? Will somebody read it out for me? Why am I doing all the hard work?
Treating a patient's severe arthritis and not knowing his or her core identity as a musician. Providing care to a woman with metastatic breast cancer and not knowing she is the sole carer for 2 young children. Attempting to support a dying patient and not knowing he or she is devoutly religious, each of these scenarios is equivalent to attempting to operate in the dark. Harvey Chochinov.
Chochino. So, if we are to treat somebody with dignity, thank you, Dr. Satyamurthy, we have to get to know the person. If possible, this may not always be possible. Whenever possible, get to know the person. Because when we treat that metastatic breast cancer, if we also know that she is the sole carer for 2 young children, our care would become different. It needs to be different. Who knows who Chochinov is? Chochinov is a Canadian doctor, very famous person. It is good to know him. Chochinov is the founder of a branch of treatment called dignity therapy. And when you look at Pallium India websites, comfortable homework for you, do anytime. Just search for Chochinov and platinum rule. It is interesting. That's worth reading and thinking about it, the platinum rule. So we'll take that lesson from Chochinov and move on. So these are the 4 usually quoted fundamental principles of medical ethics. We all know that. I'm sure there's nobody in the group who doesn't know all this. But we'll try to relate it to one another.
So
They
there
are
is a
not-
comment
Yeah.
From Dr. Punita.
Mm.
I learned
Punita,
the
would
vast
you like?
difference.
Sorry. Yeah, yes, go ahead, Sunil.
I learned the vast difference between legal approach and ethical approach. Safeguarding myself is important legally. I have ethical obligation towards these vulnerable patients.
Absolutely, Punita. Punita, we have to balance these. Whatever you think is ethically right may be illegal, and then we cannot do it. We will just accept that we are not just human beings, we are also members of a society. And the law that the society has created is binding on us. Sunita, sorry, Sultana. No, don't call it a homework. That makes it so, so hard. I said, Google for Chochinov, the name that I mentioned. Also, platinum rule. Chochinov on platinum rule. Okay.
Okay, thank you.
Now, these 4 things, what I'm saying is, you all know this. What I'll try to do is to relate them to each other and balance them. Remembering what Punita said, whatever is you think is right, or your boss thinks right, or your community around thinks it's right, if illegal, you cannot do it. The autonomy is the right over own self. That is the fundamental overriding principle of medical ethics. The first one, These are not used casually in any order. Autonomy comes first. This is my life. I have more right over this than anybody else. Tomorrow, I could very well be Sunil's patient, and Sunil has many degrees and a master's degree from Cardiff. Very good. But still, I am master of this body. So that's right over on self. Beneficence is doing good, of course. As doctors or healthcare professionals, we have to try to do good, and we shouldn't cause harm. Primum non nocere, first of all, do no harm. And we have to be fair. Equitable care has to be ensured. Justice in this case is distributive justice. If Pallium India has a certain budget, we have to balance how we spend it. It will not be equal for every patient because equitable is not equal. For those who need a little more must have a little more, and that has to be balanced, not easy. So these are the four fundamental overriding principles of medical ethics. Okay, autonomy. It is
So there is
everybody.
another comment by Dr. Yamini.
Yamini, would
I
you
don't
like to
know.
read it out? Sorry, Sunil. Not
Yeah.
that you are just to ensure more participation. Yamini, do you think you would like to read it out for everybody to hear?
Yeah. I think
Sorry, your audio is breaking. Sunil, please go ahead.
So she says, I don't know if this is related to ethics, but attendants of patients with advanced cancer do not want treating doctor to reveal the disease status to patients. It becomes difficult to counsel regarding the treatment details then. Would it be ethical to disclose the information to the patient?
There it comes. Yamini, thank you. You have brought in a very live example immediately. Okay, so I just now made a pronouncement that I have more right over my body than anybody else. Even if Sunil has a master's, I take decisions about what should be done to me. Fantastic. Agreed. And I said all that so beautifully, and then Yamini is challenging it. And as Biju Gobi says, yes, it does relation to collusion. But the point is, what Yamini mentions, I know the person has a right to know. The person is asking me, doctor, please tell me what I have. I want to know. You have to tell them ethically, right? The family thinks you're cruel. This cruel man. I don't want my father to be treated by this cruel man. The patient takes him away. The family takes him away. One possibility. Of course, they come and beat me up. That's another possibility. Beneficent, non-maleficence to myself also is important. Or they may go to court. These are all realities. But leave that alone. At that point of that patient's life, how much of trauma will that cause in the family? How much will he be affected? It is not just respecting that autonomy. Autonomy, thanks Yamini once again for bringing it out, has to be dealt with, bearing in mind beneficence and non-maleficence also. We shouldn't cause harm. We shouldn't cause a quarrel between the family members, if at all possible. So Yamini, the answer would be, I recognize the patient has a right to know. But it may not be judicious at the moment for him to be told. What I'll do is, I'll sit with the family. And if you have not discussed collusion in the classroom already, you will. And we will see how we will address it. We have to be real. And even before starting the session, I mentioned normative ethics. We have also to consider what the society considers right. We have to sit with the patient's family, 3 or 4 sessions if necessary. This is necessary, and in the meantime, get them to accept it. And Yamini, very often they may not very often. Most of the time we are able to convince them. But when we are not able to, I negotiate. Okay, I will not tell him anything today. I will, of course, we're not going to, okay, sorry. If I go to collusion, I will not complete the subject. That will be dealt with. So autonomy is not something dispensed this moment. We respect it and we'll be judicious. This is my life. I have more right over this than myself. So can I go and lie down in the middle of the road and take a nap? I feel like this. It's cold. The middle of the road, tarmac is warm. I want to lie down there. I can't. My autonomy cannot impinge on somebody else's autonomy. It cannot impinge on what the society needs. So even autonomy, though I said that's the fundamental overriding principle, has its limits. Beneficence, we have to do good. Are you sure you will always be able to do good? How about the side effects of medicines? How about the complications that may happen? We will aim to do good. And if something has a strong chance of failure or toxicity, we will inform the person, take a joint decision, shared decision making. It is not always possible for us to do good. It is not always possible for us to avoid doing harm. But these are two things that we will balance, remembering autonomy in mind, but also these. And distributing resources. Distributing resources equitably is and that is when it's money, it's easier. But when it's your time, it's more difficult.
5 minutes ago,
Some people will demand you.
So, who's speaking? Please unmute yourself.
So where was I? Yes, distributive justice is most difficult in relation to your time. We cannot be perfect, but all this, so now it's getting complicated. We are accepting all this, but we realize that all this cannot be done perfectly. You don't have to be perfect. Preeti, Meera. Vidya Saharan. You don't have to be
Yes, sir.
perfect. Yeah, sorry, I am not pronouncing your name right. None of us needs to be perfect. We cannot be.
So the principle of justice was very much in the forefront when we were treating COVID patients who were on ventilators. When there was a shortage of ventilators and we had to decide who should go on the ventilator and who should not. That was a very painful process sometimes.
Yeah, I am still, when you mentioned that, I immediately thought of the man in UP. I don't know if you had heard about that. We had blogged on it. An elderly man in UP was on oxygen. And there was not enough oxygen concentrators in the hospital. And a young man came in. There was no oxygen for him. This man took the oxygen off, collected his belongings, and limped out of the room saying, "It doesn't matter. I am 63. Let the young man live. He has a family." That was a horrendous time, but it happens all the time around us. Before I go on, I'm giving an example. You mentioned the collusion, but even simpler things. This woman was advised radiation therapy and said, we would recommend that you have radiation first. And then after the tumor has shrunk, we would like to do surgery. But there's an alternative. The alternative is we can do the operation right now, but it can be a bit more dangerous operation. And she says, I don't want to talk about it. Don't confuse me. You tell me, you are the doctor. Dr. Karishma, Dr. Nikhil, you are the doctors. You tell me, I'll follow. She is handing the autonomy back to you. Here, take it. I don't want it. Thank you very much. What will you do? Very often then doctors who believe in autonomy say, no, I can't take the decision like that. This is your life. It's your autonomy. You have to decide. What do you think we should do?
Shared autonomy, sir.
We should explain although she doesn't want to talk much about it, but still in simpler terms, we should try to explain her major risks and benefits. And even after
Dr. Nikhil, I don't want to hear about it.
Okay.
I don't. I'm sorry, I'm unable to think about it. You don't tell me anything about the disease. Doctor, you are got to be. You decide.
In that case, I would balance my medical knowledge as well as what I would do if I was the patient, or I would prefer to be done if I was the patient, or if it was my very close family member. And if still I have doubts of my own, then I would talk to any senior doctor, maybe 2-3 people more, and then decide what is best for her.
Thank you, Dr. Nikhil. You are a very compassionate doctor. Yes. Somebody else was speaking?
Thank you.
Yes,
Sir.
this is Dr. Priya.
Yes, Dr. Priya.
Sir, I would look at it in another way. This lack of, I do not want to know of this, what is happening to me, you decide, also comes from fear, apprehension, a lot of things that if I know and if I'm going to die, what is going to happen? So this is also a part of the disease process. So I would take it as that. And at that point of time, I would not go ahead and force the, decision making on her. And maybe, give it some time and then slowly go about it. I know it's a very difficult thing, but this is also a part of the treatment process, dealing with guilt, fear, and not wanting to know.
Everybody, please give an applause. Wait. Let us give first an applause to Priya. We were dealing ethics. We were concentrating on the ethical issue. Priya is looking at the person. Priya is looking at the suffering. Goli maro ethics ko. You are now looking at somebody's suffering. You sit down there. You stop talking about the diagnosis. You stop talking about the treatment. And you say, you are very much upset, aren't you? You are sad. You are afraid. Tell me about it. As Priya says, here is an emergency situation of distress. And we handle the distress. Sorry, somebody else was speaking. Sunil, today I am going to be in trouble. It's already 6:34. Okay.
Can I ask a question, sir?
Yes, please. Who is speaking?
Sir, Dr. Ambu.
Yes, Ambu.
Sir, actually, no, sir, just previously one doctor told about a shared autonomy. So I was wondering whether that kind of a concept is there, because autonomy has to be an individualistic.
Ambu,
yeah.
Thank you. I'm just coming to that right now, because we are not done with this issue. When there is this dilemma, we will respect her autonomy, yes. Refer her to oncology. Or insist that, no, you must listen. Or any other response. These are the possibilities. And Ambu, it is cruel to force autonomy on that person. Hey, Dr. Ambu, you take my autonomy. I don't want it. Your autonomy is making me suffer. And there, I won't say shared autonomy. I'll use the word shared decision-making. Decision-making has to be a partnership. We are not primarily concerned with ethics. We are primarily concerned with that human being. We are primarily concerned with doing good for that person. And here, so the important thing, Friends, everybody, autonomy is a right, but not a responsibility. I repeat, autonomy is not a responsibility. I don't want it. I say, people have told me, those who understand Malayalam will know this. In northern Kerala, where I was working, somebody said, Doctor, Doctor, I don't want to talk about it. He was laughing. Tell the person inside, that's his wife. And another man said, Doctor, if it's some good news, tell me. If it's bad news, tell them. That's okay. I won't force it on the person, Ambu. So there becomes a partnership. We remember, we are here to do primarily good. And if autonomy is causing harm, we shouldn't. This is why I said these are interrelated. I agree that autonomy is overriding principle. Nevertheless, remember, when we create these rules, definitions, etc., don't allow that to handcuff us. We are primarily concerned with people. What I may do is, if the person says, I don't want to talk about my disease, just tell me what to do. It may be okay to balance between that autonomy and beneficence and say, if I were in your position, I think I would go ahead and have the release. What's the harm in that? We have to take that role. This is what I call paternalism. Paternalism is the father telling the child, hey, you go to school. But weak paternalism, we are not saying, yeah, okay, I am taking a decision for you, go and get it. Give a little more leeway. If I were in your position, I would go for A. I would not do B. Do that. I think it's our responsibility. It's our ethical responsibility to do the best for the patient. And I repeat, autonomy is a right, but not a responsibility. Autonomy should be used as a tool, not a weapon. Autonomy again, that means it's up to the patient to decide what medicine to take. You can only prescribe. Should we get informed consent? Because some people struggle with this. This is why, though it's may seem a minor point, I brought it in context of autonomy. Should there be written informed consent? You want to give morphine? My answer is no. If somebody is coming to me for treatment, there is a principle of implied consent, which you may have heard in forensic medicine during the ethics sessions. Implied consent. For ordinary processes, medications, etc., written informed consent is not necessary. Any court will accept that if somebody came to you for treatment, they are expecting to be given prescriptions. So unless you are doing something extremely out of the way, if you are giving a chemotherapy, experimental medicine, which has a possibility of 15% mortality, then you take informed consent. If you are doing anything aggressive, interventions, a scopy, for example, then take informed consent. But implied consent will be okay for ordinary procedures. But should she be told that it is morphine? There was one hospital where early days, when there was so much of opiophobia, they did not write on the bottle morphine. Instead, they wrote the chemical formula. CH2++, oh my God, it was about 2 lines long. The intention was good. But it was done in those days. It's not done now. It is unethical now, at least the way it is now. I have a right to know what you are giving me, doctor. Give me explanations. Help me to understand. Now, when we talk about beneficence and non-maleficence, we also have to remember the double effect. The double effect is that every medicine, every therapeutic procedure, agent, everything has a beneficial effect and a potentially harmful effect. Even the poor paracetamol can have some adverse effects. So, where the benefits outweigh the disadvantages, some complications we may have to accept. Who will have to accept? The patient will have to accept. You cannot accept it on behalf of the patient unless the patient is giving up the autonomy to you. So we know that some things cause harm in some people, but we proceed and do it. But then I have the effect of explaining that to the patient and family. I shouldn't mislead them.
So even now there is morphophobia, sir. Even by educated people who Google everything and see and talk about the side effects than the effect.
Yes, doctor. I totally agree. I mean, we see it all the time. Not the poor people. They trust you more. They do whatever you want to. It's the educated people who are scared. And I mean, he's no more, but he was once the senior administrator in a cancer hospital. And he asked me, what am I as terminal as all that? He also, even he had thought that morphine is only there for terminal illness. Having said that, I will not conceal the fact that it is morphine. I'll give the explanations. I'll spend time over it. That man deserves more of my time, or that woman deserves more of my time than every other patient. But I totally agree, Dr. Biju. And for that woman whose picture I showed you, the oncologist wanted her to do an MRI scan. Do a scan and come back on Thursday to assess the progress of the disease. We keep coming across this all the time. I want to see if there is any intracranial extension. So if there is any intracranial extension, what are you going to do? Oh, no, there's nothing more can be done at this stage, but at least we'll know. What? To satisfy your clinical curiosity, you are destroying that family. So the only choice is for our organization to fund it. Should we? Personally, we would not, because that is not going to benefit the patient. If it is not of benefit to the patient, we wouldn't. We would rather spend that money on something that is more desperately needed. Money spent on one MRI scan will be enough for education of 2 children for a whole day. We support education of children's patients' families when they are impoverished, when they are at risk of dropping out. Sometimes we have to balance it. But doctor, a difficult question. Who shall I ask it to? Somebody who has not spoken yet. Srija Kailas. If your Srija is not very clear about it, Srija can't make up your mind. What should I do? Should we fund this? What can we do, Srija?
No.
If you are not sure of what is the right thing to do, you transfer the decision to a committee. Not a committee that will take 2 months to take a decision. Somebody available, or involve more than one person.
Yes,
All
yes.
ethical dilemmas will come to you. Not only to Srija, to everybody here. You may not know what is right and wrong. And when you don't know, we consult colleagues. 3 people together take a decision.
Yes, yes.
That may be a formal ethical committee, but formal committees take time. You usually refer things to committees when you don't want to do anything. But here you create a practical committee that will be active today and document it.
Yes.
These 3 doctors, or this doctor, this nurse, and this physiotherapist together have discussed this. We feel the right course of the action is such and such, and you sign it.
Yes.
Thank you, Srija. Okay. Though the national...
Sir, excuse me. Can I ask a question on this?
Sure. Who is speaking?
I'm Dr. Dimple.
Yes, Dimple.
Isn't it relevant to know about the spread of the tumor before embarking on radiotherapy followed by surgery? Because why is an MRI scan completely wrong?
Oh, by no means is an MRI scan completely wrong. If it is only to assess the tumor, spread of the tumor, in the case scenario that I mentioned, if it will not make any impact on the treatment, when the oncologist is saying, okay, even if it has spread into the intracanal space, we cannot do anything. No more radiation is feasible. We are given the maximum. Only in that context. Dimple, thank you for asking the question so that you gave me an opportunity to clarify it. All MRI scans are not bad. Oh, of course not. I myself had MRI scan done on me. So that can be life-saving also. But just to assess spread of tumor, when I'll change that slide, Dimple, to clarify further for the future, only when it is now unlikely to make an impact on the treatment. That's the situation.
Thank you, sir.
So though the National Cancer Grid has said that in advanced metastatic cancer, do not treat patients in the ICU unless there is an acutely reversible event. Though they have said that, you know that all over the country, and people with advanced cancer die in intensive care units, isolated from loved ones, subjected to artificial interventions. And the patient who has had experience in the ICU, a lot of them say this, don't take me back there. And the son says, don't go by what she says, doctor. We want the best of care for her. Money doesn't matter. She is my mom. I want to do the best thing for her. So already this point was brought out about collusion earlier. This is a situation that we face all the time. And if you respect the patient's autonomy, you won't take her. But you also know that dead people do not go to court. The living son may go to court. The wiser practical thing will be to take her to ICU. But as I said, this is a clear position statement from the National Cancer Grid. Do not treat patients with advanced metastatic cancer in ICUs unless there is an acutely reversible event. So what I'll do is I'll sit down with the family. I'll acknowledge their suffering. I'll tell the son, I have respect for you. You love your mom so very much, very obviously. And then he may cry. He may say, my mom is everything to me. She has practically given up her life for me, etc., etc. And with that, we are on the same side. And I'll say, you want to do the best for your mom. I want to do the best for my mom. And if the hospital rules will permit, I'll get the son to change and take him inside the ICU and see what happens there. So we try to achieve some consensus, and you may talk about this more when you deal with end-of-life care. I'm not going to the details. So here again is a case for shared decision-making where we discuss. In the meantime, while the son takes a day or two to think, you do not escalate life support. You do continue to do whatever you are doing and give the son time and then arrive at a consensus.
Sir,
Anji.
This thing. Sometimes what happens is that many patients' family feels that only if they go to ICU, they'll get access to maybe better nursing, or maybe the needs of the patient will be addressed better. So sometimes that is a very real issue, because in the ward, you might have around one staff who's taking care of 20 patients. So this is, they also know that, okay, I don't need a ventilator. I don't need XYZ things. So at that point of time, it becomes a little difficult, because they also know that in the ward there are 20 patients and one staff. So
Priya,
yeah.
what are 6:50? Sunil is going to be very angry with me today. I'm in trouble. But Priya, I'm asking you a difficult question. Are you able to think about your own death?
Yes, sir.
You are. Okay. Then homework for you. You don't have to answer now. You have to think about what will be the most important points for you at the end of your life. Remember, I am not talking about all intensive care. My God, I have been an intensivist. I have been party to saving so many lives with intensive care. When life is salvageable, by all means, but humane with humanity. But here we are talking about advanced incurable metastatic cancer, and we need to think what are the important things for us at that point of time. Is it time with the family? Is it a kiss from your grandchild? Is it being told, we love you, mom? Is it being able to tell your spouse, I'm sorry if I have hurt you at any point of time? I love you. Aren't those things more important? You have to think. So I know what, this is something that I keep hearing, Priya, from doctors. We need to give the best care for him. We need to give the best care for her. There is a one-to-one nursing in ICU. Yes, you have it, but you don't have a love machine and a connection machine and a human relationship machine. So when somebody, there's another thing, Priya, when somebody says, don't take me back into ICU, you sit down with the patient and find out why. 1/3 of all patients develop delirium within 48 hours of intensive care. In intensive care units, without an effective sedation protocol, it rises. 2/3 of all elderly get delirious within 48 hours. Then you tie them up. Physical restraint has been shown to increase the chance of agitation 44 times. So we will discuss. Do not escalate life support. Give time. Arrive at a consensus. Hey, why am I giving that homework only to Priya? Maybe anybody here who is able to think about one's own mortality, please make a list of things that you will consider most important at the end of your life. During that period, maybe a month. What all would you like to do? How would you like to spend the time? But I am moving on to something fringing on the problem of euthanasia. Everybody here must have, you are palliative care physicians, you must have come across this question. Please kill me. Can you respect that autonomy? That person is giving up the right to live. In such issues, we look for the question behind the question. I wish I had half an hour to talk about it, but I don't. I'm rushing through it. We look for the question. Don't look at every question literally. When somebody is asking, why am I alive? There's 5 questions behind that question. Look for that question. Will you respect her autonomy? She was saying that because she couldn't tolerate the pain. You give pain relief, and the next day the person sits up and takes idli sambar. So again, that limitation of autonomy. But like that, in the vast majority of patients, palliative care is the viable alternative to euthanasia. Not statistically correct, but I would say 9 out of 10 patients who request euthanasia, once you relieve their symptom, they will withdraw that request. But there will be that minority. You don't have time now, but at some point of time, get Sunil to tell you the story of Sudharan and Sudha. Sudharan was a patient and Sudha was his wife. And Sunil and I both found that experience extremely disturbing. But anyway, whether it's right or wrong, the question doesn't arise because legally, euthanasia is murder. As simple as that. Not even manslaughter. It's murder. You are taking a willful decision. And we don't want to do illegal things. I tell the person in those situations where I am unable to relieve the suffering, I hear what you are saying. I'll continue to look after you. I'll try to make life as livable for you, though I have not been able to be of much help yet. But this is something that I cannot do. That answer becomes necessarily only in a small minority of people. 4 minutes is what I have for discussion. I'm very sorry about this, but we did get some discussion squeezed in between, didn't we? So, hey, there are many people here who could be fellow faculty members. Hey, Nikhil had asked, when we talk about confidentiality, is it fine to discuss about a patient without revealing the identity? Nikhil, my conviction is that it is okay, especially when you do it for teaching purposes, for awareness purposes. Once the person's identity is not revealed, it's okay to reveal, share stories. Maybe if there's a, we'll have to make sure that the identity is not revealed, or we'll have to get consent. I mean, like, was there any other question? Anybody wants to?
Sir, one question,
yes.
sir.
Yes, Ambuano.
Yes, sir. Sir, actually, this is regarding that euthanasia thing, sir, because actually in 2013, sir, I think it's 2013 end of 2014, and the first few months, actually, sir, in Death with Dignity, that program Parliament they conducted, sir, actually I think, sir, I'm not sure, so, but I think the gist of that discussion was that euthanasia is a necessity in some cases, something like that, that discussion was there, sir. But actually now, sir, you are telling that since palliative care is improving and improving, euthanasia will be becoming obsolete soon. Is it what, sir, you are telling, sir?
No, Ambu. No, very clearly not. Ambu, at that time also, and now what I say is, the vast majority of patients, if you provide palliative care, you will not need euthanasia. I still say that. But I'll also say that in a minority of patients, I rushed through that too fast, Ambu. That's why you caught me out. See, in the minority, where you fail to improve the quality of life, you have to balance the individual's interest with the society's view and the law. So if Ambu is practicing medicine in Switzerland, you would refer the person to the appropriate person, because the person has a right, legal right to practice it. I am not sitting there in judgment about the ethics of it. I am not a judge. The law permits it. If I am in Netherlands, I will refer the person to the appropriate person. I am not ready to do it yet. But in India, savali nahi paida hota.
So there was one thing that you mentioned about Switzerland, where euthanasia is legal. Even there, the doctors who had referred the people for euthanasia, they had regretted it later on, saying that 85% of the patients could have been managed with very good palliative care, and they wouldn't have needed euthanasia, as you said, sir.
I'm sorry, Dr. Biju, you know more about it than I do. But this point is important. What is expected of us, ethically and legally, is reasonable expertise and skill. I know that what is not treatable in my country may be treatable elsewhere. But I have to do with what is locally available and realistically available. These regrets will happen. And in the field of euthanasia, so many people are living with regrets. The family lives with so much of guilt. It's also true. Not necessarily, but very often. Dr. Biju, I totally accept that there will be questionable issues, questionable situations, regrets. I wouldn't be surprised if some people even get mental disorders because of those issues. That's true.
Sir, I will ask, have you seen any patients consistently asking for euthanasia, even when you have done everything possible for the patient?
Sir, I have.
Every one of us would have, I mean, anybody who has practiced palliative care for more than 5 years in this group would have had the experience.
So I had a very, very tough experience. This was a very learned lady, very strong-minded learned lady who was having a lot of a host of problems, end-stage cardiac failure, COPD, diabetes, hypertension. She was, and she absolutely refused all medication from the cardiologist, and he was at his wit's end, and he said, okay, then you go for palliative care. And he called me and then handed over the patient to me. But then again, when she knew that I was a palliative care, the first thing, she befriended me, and then first she asked was, kill me, give me euthanasia, do euthanasia. I said, madam, that is the only thing that I cannot do, but I can take care of you. And she fought with me, she begged me, I mean, she did a lot of things, but I said, no, I will take care of you. And I did that. And towards the end, she lasted almost 2 to 3 weeks in that situation. I took care of her breathlessness, I took care of her agony, I took care of her symptoms. And she was, till the end, she was conscious, and she was thankful that we didn't do anything more than that. We supported.
Yes, Dr. Biju, that happens so often. Congratulations on what you did for that person, and thank you for what you did for humanity. But you will come across the other side of the story. You do everything in your power, and the suffering continues. They suffer, you suffer. Sunil and I suffered with Sudhakar and Sudha. I have exceeded time. Already his presentation time. Sunil,
Sir,
back
there
to
is,
you.
I think, one more question you have to answer about advanced directive. Is there provision for advanced directive in India?
Would you like to read the, is there any provision for advanced directive for patients in palliative care for future medical care? Yes. One word answer is yes. So India does not have a law covering it. In the absence of law, decisions of the Supreme Court hold valid. If there is neither, then it would be statutory bodies, medical council decision. But today, medical council decisions are invalid because there's a Supreme Court judgment. The Supreme Court judgment said advanced medical directives are valid. But they put in one condition. They said your advanced medical directive has to be signed by a judicial first-class magistrate. Bapre. I took all the trouble to create my advance directive, discuss with my wife, discuss with my children. One of them did not want to listen to it. Then I nagged him. Eventually, they all agreed. Now you're saying that I have to go to a judicial first-class magistrate and wait in his corridor as if he has nothing else to do. So that's one of the things, Doctor, that the Supreme Court is hearing again. I hope things don't get worse. Yesterday's verdict, yesterday's discussion is there on the press, on the media. Today, there must have been a hearing again. I am watching out for the news about that. Maybe there will be more decisions now, but eventually, there is a law has to be enacted. When a law is enacted, that will be paramount. Actually, in 1996 or 97, I can't remember, the government of India had put up a draft law on the website and asked for public comments. Oh, it was a disaster. Oh, it was put up as a draft. They got more than 1,300 responses, and it has dropped. But now people are asking for that legislation again. So once a law comes in, things will be simple. But as of now, advanced directives are valid. As of today, they are valid, provided there is a counter signature by judicial first class magistrate legally. Somebody was Sunil, when you are fed up with me, just stop me. But
last question: is there a difference between living will and advanced directive, or it's Is it
No,
the same?
no. Living will is the ordinarily used expression. Advanced medical directive is a little more medical. Living will is too small. We doctors want long words. Because we can't find a Latin word for it, we use advanced medical directives. The same thing.
Yes.
Yes, Sunil.
Now, if I think we need to go to the patient story now.
Hey,
If you have,
Sunil,
yeah.
just one question from Vidya Saran. Do we have a session on palliative sedation?
And no, we do not.
So whoever is doing end of life care, Sri Priya, please make a note. Sunil, please make a note. Whoever is doing the end of life care discussion, if I am doing it, I will have to be reminded, please make sure that palliative sedation gets discussed. Very important. Because that fine line between euthanasia and palliative sedation is very important. Yes, Dr. Yadav, yes. Euthanasia is, every palliative care physician comes across that so many times. And as a surgeon, you also have come across this. Thanks. Back to you, Sunil.
Okay, so I will move on to the patient story, which will be presented by Dr. Bindu Kesarmal from UK. Dr. Bindu, it's over to you.
Good evening, everybody. I'm Dr. Bindu. I work in the UK. I work in specialty stroke department. I'll be presenting a case today. This is about a 68-year-old gentleman who was diagnosed with right middle cerebral artery infarct, who was then thrombolized. Following thrombolysis, patient developed right malignant MCA syndrome. So patient presented with left-sided weakness, left facial droop, and speech disturbance. Patient was right-handed. In the past medical history, he had diabetes, hypertension, and hypercholesterolemia. Patient used to work as a taxi driver. He was retired now. He never smoked or consumed alcohol in his life. He was independent in all his activities of daily living prior to admission. Upon arrival to ED, patient was reviewed by the stroke department. Family mentioned that patient woke up around 7 a.m. in the morning. He felt normal. At 9:20, when he was driving to supermarket, patient felt like his left arm was heavy. He pulled over his car and rang his wife. His wife could not understand what he was saying to her, so she rang ambulance. Patient had left-sided weakness, left facial droop, and speech disturbance. Vision and hearing was normal. No double vision or imbalance. He denied any headache or vomiting. No history of fall. Onset of symptom was 9:20. Time of arrival to hospital was 10:30. So patient was still within the window for thrombolysis. On examination, patient's GCS was 14/15. His observations were stable. He had left facial droop, dysarthria. Power on the left side was 2/5. He had both sensory and motor inattention. We could not assess coordination gait due to his reduced power. There was no nystagmus. Other systemic examination was unremarkable. Initial investigations were done like ECG, which showed sinus rhythm. All the routine initial blood investigation were within normal range. The first CT head scan was done, which did not show any signs of acute stroke. Because the patient was less than 80 years old, we also have to do a CT angiointracranial to consider patient for thrombectomy, which was also done. That also did not show any thrombus and no contraindication for thrombolysis, so patient was thrombolized. 9 hours following his admission, on-call doctors were called to review patient because his GCS had now fallen down to 12 and his left-sided weakness had worsened. Repeat CT head scan was done, which showed malignant right MCA infarct with midline shift. For those who are interested, malignant right MCA infarct is when There is sudden neurological deterioration in a patient with stroke due to surrounding edema of the infarct, and there is midline shift. Patient underwent right hemicraniotomy under a neurosurgical team. Following that, he developed subdural empyema, for which he was on prolonged course of antibiotics. He then went on to develop seizure, for which he was on antiepileptics. Then he was treated for hospital-acquired pneumonia with antibiotics. So this was over a course of 3 to 4 months. Every now and then he would develop infection, for which he would be on antibiotics. He was not eating and drinking well. He did not have capacity as well. So he needed 24/7 nursing care. He was nursed in bed. And with the therapy also, he had not made any significant improvement. He had no sitting balance. Medical team, along with other members of the NMDT, at that point felt like he was approaching end of life care, which was discussed with patient's wife, who insisted to continue investigating and treatment plan. Patient's wife also would fight with nurses not to give any pain meds to patient, as it would make him drowsy and interfere with his progress. Patient was the only earning member in his family, and he handled all the finance. It was a consanguineous marriage. Him and his wife, they had one son now who has a disability, and wife looks after him. Prior to this, their wife had 3 miscarriages, and 2 babies had died between like 3 to 5 days after the delivery. Wife is struggling to manage her disabled son at home and to visit a hospital every day, as this patient had been in hospital for 3 to 4 months now. She did not want to address this issue. Wife may have undiagnosed depression in the background. Multiple family discussion had taken place with patient's wife regarding resuscitation status, pain meds, and end of life care, with no positive outcome. Wife also refused any support from psychology team or spiritual support from imam at the hospital. List of patient medication: clopidogrel, sodium valproate, atorvastatin. As for pain, he was on paracetamol and tramadol. Patient was reviewed by the pain team, but then wife did not want a patient to be started on morphine. Main concerns here is medical team decision is not to resuscitate patient. When this was discussed with patient's wife, she wanted her husband to be resuscitated and threatened to sue the doctors if patient was not resuscitated at any point. Patient was constantly in pain, but wife was not allowing nursing staff members to administer analgesics, especially morphine. Wife not accepting the fact that patient is approaching end of life care now. She is not in agreement with any medical decisions. All her family, rest of the family members, they lived in Pakistan, so she did not have any family support here. And also we did not have any other members of the family to discuss these issues with them. In summary, it's a 68-year-old gentleman who was admitted with left-sided weakness, left facial group, dysarthria, who had left-sided inattention, was thrombolized. Patient then developed malignant MC syndrome, for which he underwent hemicraniotomy, complicated with subdural empyema on prolonged antibiotics. He was treated with multiple courses of antibiotics. Patient had not made any significant improvement and is approaching end of life care now, but wife wants a medical team to carry on investigating and treating patient. So these are the points that I would want to be discussed in the class today. Thank you.
Thank you, Dr. Bimbo. So there are 4 questions. Any of you have any comments? Please do it now.
Can I know what is the source of pain?
Because of the he had pain at the craniotomy site, and because he was nursed in bed, he was starting to develop bed sores. And as he had no sitting balance, he could not sit even on the rehab chair as well. So it's like he had pain generally all over the body.
So I am sure there are many practitioners here, and they might also have faced situations like this. So how do you manage such situations? Medical team has called, they don't want to resuscitate, but wife is saying need to resuscitate. So
I think
what do we do in such situation? That was the first question.
One question, sir. Hello.
Yeah.
Sir, we can try Miss Park pain just between open patch or internal patch in this case. If the patient is means subconscious.
So you are saying patches, fentanyl or buprenorphine patch, transdermal patch can be used
Yeah,
for
for
pain
pain
management.
purpose. Yeah.
Okay. So I understand that the patient's wife actually denied using morphine. So we don't know why it is. Was it explored? We don't know. But I think we need to discuss the difference of opinion between the medical team and the wife.
The actual problem is the conflict between what the doctors feel is best for the patient and what the wife's understanding of the medical condition is, because the patient is not in any position to decide his own treatment. So this conflict resolution is the key to going forward with the treatment.
Yeah, I can see that from the chat, everybody is talking about counsel the wife. So counseling for the wife need to discuss with other attenders, giving her time to think and understand the situation. Yeah, that is the common point in the chat box.
I think we need to understand what it means to the wife to allow the to stop either use morphine. Is there any spiritual, I mean, some cultural understanding about the use of morphine and regarding other decisions that we are not able to understand as we belong to some other? So that could be some reason.
Sunil,
Okay.
So
Yes.
I think
yes, Shravani, complete.
so. I think the cultural background of the patient
Yeah.
maybe
Sunil,
some that
Sunil,
is not able to understand why she is refusing some medication, or I think we need to discuss about that.
Sunil, I have a meeting to start at 7:30, so I'll have to leave at 7:25 to prepare. So shall I make a couple of comments? I wish I could wait till the end, but some points need to be made.
Yeah.
See, Bindu's second question. Considering the wife's current mental state, what is the best way to discuss end-of-life care with her? Bindu, we are not ready to discuss end-of-life care with her. Bindu, will you take us back 3 slides? One more. Wait. Friends, here we have clearly a person in much greater suffering than the patient. Think of her situation. She is all alone, nobody to support. Only earning, he was the only earning member. She now can't even access his bank account. She has possibly no money. The son has a disability. How will she take care of the child? Leave alone depression. This woman has to be in grief, anticipatory grief. And grief can be two kinds. It can be the grief of loss. I'm going to lose him. I'm going to lose my partner. I'm going to lose my son's father. But it can also be restoration grief. Restoration grief is the grief that comes out of failure to adapt to the situation where instead of two parents, there is only one parent. How to carry on life. See, she is almost an impossible position. I wouldn't be surprised if she thinks of killing the child and killing herself. This is a woman at very grave risk. Bindu, thank you. But can you bring us back to your questions in the last slide? So coming to the second one, without getting her trust, it's impossible to make progress. And we don't, by this time, I don't know, Bindu may know, very often there are two groups, armies fighting. On one side, it's the woman alone. On the other side, it is all the staff. When she is opening the door, all must be looking at her. Here comes our enemy. The unreasonable woman. No, of course it doesn't happen, Bindu. I am only theorizing the possibility. Here is the unreasonable woman who is preventing pain relief for the poor man. And once we start considering herself as an enemy, we have lost the game. One, Rosalie Shaw, the great palliative care physician, Australian from Singapore, talks about jumping over the net. Here's a game of tennis. She is on one side of the court. All of us are on the other side, arguing with each other, counseling, trying to get her to understand our point of view. What is necessary is to jump over the net, go to her side of the court. I don't know if that is possible. Somebody sitting down beside her and saying, you are suffering so much. I wish there was something I could do to help you. Unless she finds a friend among the team, this is impossible to solve. And then, without telling her anything, the counseling at this stage is only listening to everything that she goes through, till she feels she has one friend in the whole team. And only then we can make progress. That's one point I wanted to make. Sorry, I'll have to leave soon. But the other point is, despite everything, if she is refusing to give pain relief, after all the explanations, these are the situations it's better to get a committee involved. You form an emergency ethical committee, and together you decide. And the committee may have to take a decision and tell the woman, we are duty bound to treat his pain, but we promise to use medicines that will not interfere with the progress or interfere with his improvement. We will use safe enough medicines, but this is our ethical duty to do to the person, and we must do it. So these are the two suggestions from me. I wish I could stay on to listen more of the discussion.
Sir, are there any extended release patches? Because her main issue is that the pain medicines make the patient drowsy. So, I mean, if there is something which is an extended release, it could avoid the drowsiness, or just a thought.
Dimple, I leave you all to discuss that. There are extended release analgesics, of course, at least 2 kinds, but I don't think that's the answer here. Because even if it's extended, even if you cause the sudden drowsiness after a single dose, it does cause its own side effects. But these side effects are not going to be harmful for her. That's the major issue. If you try to bypass it by using patches, the issue is still there. And then things are worse because she finds out that even if you take the patch out, it's still active for 24 hours. She'll be absolutely mad. Sorry, friends. Please continue the discussion. And Sunil, with your permission, I'll leave. Sri, I'm leaving.
Thank you, sir.
Oh, before I go, Sri and Sunil, I got a confidential feedback from the team that there were some difficulties they had about our management of the course. So maybe you need to give everybody an opportunity to give feedback in confidentiality preserved, which will not be disclosed, identity not be disclosed to anybody. Something like our inability to respond to questions, inability to answer calls, etc., etc. So maybe at leisure you will have to address that also. So friends, I enjoyed this discussion. Thank you very much for your participation. Good night.
Thank you, sir.
Okay. So this is Dr. Bindu. Is the patient still in your hospital, or have you managed this situation somehow?
We have managed him, sir.
Okay, what did you do?
So, can you hear me? I think there is some disturbance on my side.
Yes, yes.
Okay. So yeah, a patient kept refusing help from the hospital imam, but still we, couple of doctors discussed with the hospital imam, so he was able to visit patient and just start the talk with her casually. And then we had multiple discussions with her. I think nearly 4 to 6 times. The medical team and everybody sat with her, and patient now is in hospice.
Okay.
Yeah, because she said she could not manage him at home because she's got a son who needs a lot of attention as well. So that was her decision towards the end.
Okay. So if this patient is in India, what can any of you tell us what would have happened?
So I had a similar patient who was, in fact, I'm treating her even now. The family consists of 3 sisters, 3 siblings. 2 of them were agreeable to whatever I was trying to tell them, that palliative treatment is enough, but the 3rd daughter was always against it. She wanted active treatment, though it was not very conducive for the mother. The mother was the one who was the patient. And we had to have repeated counseling with the whole family. Ultimately, as Rajagopal Sahab was saying, the daughter was actually disagreeing. She was only disagreeing because she was the closest with the mother, and she probably loved her more than the other 2, because the other 2 were actually staying in US, and they had just come to see her once in a while, whereas this 3rd one who was opposing for all the treatment was the one who was taking care of her. And so she was very close. So that's why she was wanting the best for her mother, though what she was saying was not what is conducive for the mother. Then I said I could understand that she is the most closest, and that broke her the ice, actually. Then when she knew that I'm with her and I want the best for her mother, like the rest of the people, then she agreed, and now we are doing a very good job of controlling her pain and her suffering. And in fact, she is still alive. She is in end of life care treatment right now as we speak, but she is so calm, so quiet, and all of them have accepted, and they are all at peace right now. looking at her, saying that, this is exactly what we wanted, but we didn't know how to get it. So,
Yeah, that's a good experience. This is what Rajagopal sir at first told. Go to the caregivers court and stay with them, so that they should feel that we are supporting them. Here also, um, uh, that's what sir was saying, to make a friend, or from our team at least one of us should be able to get into her mind. So that's the only way to influence her. And maybe the other factors Dr. Bindu has told, the depression, all might be playing here, but still she should feel that she is getting some support from us. And our feeling and our attitude that uh, she's against us, the medical profession, that actually need to be changed. Then only we can have an open meeting with the wife. Otherwise, that will every time it is going to be going in opposite direction. And suppose this patient, the medical team think that okay, this is the life is not salvageable, and according to even according to Supreme Court, when the um, uh, I am introducing another word which we should not use. Actually, uh, Supreme Court has introduced something called a passive euthanasia. So that was a misleading word actually, because euthanasia we internationally we consider it as always passive. So what Supreme Court has called passive euthanasia is withholding or withdrawing life support when it is futile. So when so in this patient, any life-sustaining treatment or the treatment resuscitation, that's a life-saving treatment. In this condition, in this patient, it is not going to be beneficial. So we can actually withhold, but there is some procedure for that. That's the biggest problem. This has to be go to court, and we have to get the um, permission from the magistrate after constituting a medical board by the magistrate. So it will take time. So rather than that, that's the according to law. If you want to go, that should be. But if we are unable to, we should constitute a ethical committee, including different members from the hospital, and then we have to make a consensus. And Dr. Bindu was talking about mental capacity. So, Dr. Bindu, what was that question about mental capacity?
Can you please go back? I think Shripriya is handling the slides. I can't.
Yes, Rama.
No, just read Shripriya. You need not share.
So anyways, I'm not appreciating. The third question, I suppose, sir.
The patient has no mental capacity and next of kin is not in agreement with medical decision. How do we move ahead with further treatment plan? So I think what we have discussed is applicable in this question also.
Okay.
Can nursing team administer analgesics in the best interest of the patient? Did you get time to explore why she don't want to give morphine or any other medication?
When we spoke to her, what we realized is, where she had so many miscarriages and the incidents during that time, she feels like when the doctors back home had given her a lot of painkillers, that was causing her not to get better, or that was basically, like her words were, that was what because of which my babies were getting killed. That's what she was feeling. I think it took us a lot of time to explore that and to explain that that's what is not happening in your husband's case, because every treatment that he had here, like we thrombolized and he had malignant MCA, then for which he had craniotomy, for every treatment we were giving him, he was developing a complication because of that. So I think she was feeling like what happened to her in the past, maybe that would happen to her husband, that the medications would just make his course worse.
Dr. Bindu, one question. In your case history, you mentioned that there was no acute, infarct or thrombosis. Or then why did you go for a thrombectomy or thrombolysis?
So if there is no infarct, then only we can thrombolyze. If there is already signs of infarct, then we cannot thrombolyze.
Yeah, but you did the angio and there was no thrombus. That's what you said, right?
Yeah, clinically we still thought it as a stroke.
No, but then again, when you had very good evidence with the imaging, why did you go for a thrombolysis?
If there is no thrombus, also we thrombolyze here. That's the guideline.
So what?
Not necessarily that all the time they have.
Is that an accepted standard guideline or?
Yeah. Even if there is no thrombus, we do thrombolyze if they are within the window, which was right because in the following CT which he had, it showed an MCA infarct.
Couldn't it have been like a TIA, a transient phenomenon?
Because he had symptoms. His NHS score was 15. I did not mention the score because I didn't know if they used that scoring in India. His NHS score was around 15. So with TIA, they wouldn't have that high score on admission, and symptoms would have resolved within a couple of hours.
Okay. So just one more comment on the medications. So it is said that tramadol can actually reduce the seizure threshold. So this patient is already having seizures and putting the patient on tramadol. If possible, I understand the situation that she at first did not agree with your decision on giving other opioids. So this is something which we need to keep in mind. But I haven't seen any patients with seizure precipitated due to tramadol, but theoretically it is possible. And each and every books and journal says, okay, this can happen. So that's one thing I want to keep you in mind.
Thank you, sir.
Yeah. So actually, this patient's wife, she even had experienced the death of her 2 babies and a lot of other bad experiences. Not because of the problem with the medical profession, but it has happened. So all those things she's perceiving as bad things, as you told, that all would have added to her decision. So, but I'm happy that at last your team were able to make her convinced about what treatment would be beneficial for the patient. Okay. I think there will be many more questions, but we cannot prolong the session now. It's 7:14. So I would like to thank Rajagopal sir as well as Dr. Bindu for presenting a patient story, which actually generated a lot of questions, and even there will be some questions that are unanswered. And we in ethics there is something called as absolutely right and absolutely wrong. So this is what we have to also keep in mind. And thank you all for your active participation. And thank you. So over to Shripriya.
Thank you, Sunil sir, and thank you everyone for joining us and making this session also most interactive. And as already told, since we have already run out of time, This is Sri Priya along with Dr. Sunil Kumar signing off from the Tips Eco Hub. See you in the next session with another most important topic and an eminent faculty. Till then, everyone, take care. Bye-bye. And please don't forget to leave your feedbacks.